Please, can you hear me?
We can hear you. You can go ahead, please.
Okay.
I think Dr.
Thank you.
Kalia has not.
You can go ahead, you have the floor.
Good morning, everyone. I'll be taking practice question 10. My name is Okora from Aduka. The question goes this way. A young woman with 4 weeks history of difficulty raising her arms when combing her hair and 2 weeks history of progressive weakness in standing up from the chairs and climbing stairs. She was started on treatment for hypercholesteremia 6 weeks ago. A. What other history would you like to take from the patient? List 3 differential diagnoses and state why. What is your final diagnosis and state why? What is the name given to each of the following? Rashes around the eyelids, rashes on sun-exposed areas, rashes on the knuckles of the fingers, roughening and cracking of the lips, of the tips, and sides of the fingers. How would you treat the patient? So for the other history I want to ask for history of generalized malaise, weight loss, and fever, which is usually some of the constitutional symptoms that may be seen in this patient. And also weight loss could also point to a possibility of an underlying malignancy. Muscle pain, muscle wasting, and joint pains, I also want to know this. Especially looking at the muscle pain, some authorities can use it to differentiate other differentials of this condition. I want to know about painful discoloration of the digits. My thoughts will be on possibility of Raynaud's syndrome, rashes around the eyes, upper chest, back, or joints of the fingers. I want to ask of photosensitivity, oral ulcers, dryness of the eyes, skin thickening. I'm thinking of other coexisting or mixed connective tissue disease in this patient. History of chronic cough, abdominal swelling, change in bowel habits, swelling in the breasts. I'll be thinking of an underlying malignancy in this patient and a possible source of this malignancy. Then weight gain, easy bruising, neck swelling, cold or warmth intolerance. We all know that some endocrine problems can also present this way. So these are some of the questions I want to ask the patient. So the differential diagnosis I have will include drug-induced myositis, polymyositis, dermatomyositis, antisynthetase syndrome, and endocrine abnormalities like hypothyroidism, hyperthyroidism, and Cushing's syndrome. All these will cause proximal myopathy. However, there are certain features that could tilt us towards one or the other. For instance, the endocrine abnormalities, we will now have to find other histories that are in keeping with such feature. For instance, if a patient has proximal myopathy and the patient is gaining weight, has easy bruising or history of intake of steroids, so we may have to think of Cushing's syndrome. So the same for dermatomyositis, the patient could present with some skin rashes. Polymyositis will also come with proximal myopathy. However, there will be no skin affectation. And usually, the polymyositis is usually painless when you compare it with dermatomyositis. Now, there may be some drugs also associated with this condition, such as statins, steroids, and so on. So these are some of the differentials I want to consider. So what is your final diagnosis? So my final diagnosis here will be dermatomyositis. Looking at the differentials I've stated, it appears as though dermatomyositis is one that is possibly commoner among all of them. And like I said, the other ones that I listed, there was nothing, apart from the drug-induced anyway, there was nothing pointing to an endocrine issue as a cause or the other ones I listed. However, for dermatomyositis, it's relatively commoner. And even though this patient does not have some or any skin manifestation, like from the history from the question that would have been painted, However, it's worthy to note that dermatomyositis can also present without skin skin manifestations, which we usually know as dermatomyositis sign dermatitis. So it's worthy to consider. However, truthfully, I had to consider this diagnosis when I had seen the stem, the question following this stem. Otherwise, I would probably have chosen drug-induced myopathy. So what is the name given to each of the following? So rashes around the eyelids, like we all know, that's heliotrope, which is usually a purple discoloration of the eyelids with periorbital edema. Rashes on the sun-exposed area, usually you see it around the chest and the V-shape of the neck and the back, upper part of the back, which we know as the Shaw sign. Rashes on the knuckle, we call it the Gotron's purple, which is well marginated, voluminous, and lichenoid purples over the knuckles. So roughening and cracking of the tips and sides of the finger, which is also known, which is called the Samit sign. So how will you treat this patient? Now, having taken a history from this patient, examined and investigated, and confirmed my diagnosis. So I will now go ahead to involve multiple specialties in this patient, which will involve the rheumatologist, dermatologist, physiotherapy, and also the psychotherapy in this patient will also be important. The therapy can be both general and specific. It's important to encourage bed rest, and even at that, also list this patient in some form of exercise. Then the treatment specifically involves steroids, where systemic corticosteroids are traditionally given, usually prednisolone at a dose of 0.5 to 2 milligrams per kg, up to a dose of 60 milligrams per day as initial therapy. And then it's usually continued at least 1 month after the patient's symptoms, that is myositis, has become clinically and examinedly inactive. Then, of course, we have to taper down the dose. However, early introduction of some drug-sparing therapies such as methotrexate, mycophenolate mofetil, azathioprine, cyclosporine is also advised. There's also room for IV immunoglobulin therapy in cases that appear recalcitrant. I also saw somewhere that you can also use the anti-CD20 medication, rituximab, for these patients. And then in taking care of the skin manifestations, it's important to educate the patient to avoid sun. You can also use sunscreen. There's rule for methotrexate. There's rule for hydroxychloroquine, in which we can use methotrexate if that does not work. And all these, it is important to treat the underlying malignancy if you suspect or find one, because he said that when you manage underlying malignancy, it is easier, or it leads to better outcome in treating these patients. So I'll briefly go through dermatomyositis. It's an idiopathic inflammatory myopathy with characteristic cutaneous findings that occur in children and adults, usually affect the skin, muscle, and joints. The neoplastic subtype is seen in up to 30% of adults onset dermatomyositis. The most commonly associated malignancy include ovarian cancer, primary breast cancer, colon, lung, prostate, pancreatic, and gastric cancer. The pathophysiology behind this condition is not fully understood. However, it is suspected to result from an underlying alteration in cellular and humoral immunity. Neoplastic dermatomyositis is believed to be the result of interaction between several tumor-derived biological mediators such as hormones, peptides, antibodies, cytotoxic lymphocytes, and paracrine mediators. The finding of specific myositis-specific autoantigens such as the histidyl tRNA synthase expressed at higher levels is in myositis has heightened the possibility of autoantibody across the activity. These findings support the possibility that myositis symptoms may result from cross-reactivity between autoantigens against cancer cells as well as those of regenerating cells. So these are the clinical features, some of which we've mentioned before. Usually, patient presents with proximal myopathy, and there may be or may not be some skin manifestations such as the heliotrope rash, Gotron purple, like I've mentioned before. And investigations that will be needed in this patient will include creatine kinase and aldolase and LDH, which will all be elevated. Immunologic assays such as the anti-MI2 and anti-JO1 may also be seen, as well as ANA. And anti-P155 are more commonly associated in cases of cancer-associated dermatomyositis. So the muscle biopsy, EMG, and MRI may also be asked for. So there's this criteria, the Boham and Peter criteria, which has a symmetric proximal muscle myopathy, the muscle biopsy, evidence of myositis, increase in serum skeletal muscle enzymes, then characteristic electrogram pattern of myositis, and typical rash of dermatomyositis. Now, to use this criteria, if you find a typical rash of dermatomyositis with 3 of the above, of any of the above, you can see that the diagnosis is definite. If you find just the typical rash with 2 of any of the above, the diagnosis could be probable. It's a probable diagnosis. But if you find only a typical rash with only 1 or even none, so you can just say it's possible that this patient has dermatomyositis. So the management is, as I've said before, it's important to investigate this patient, treat underlying malignancies if there are any. So the mainstay is steroid, and you can also use steroid-sparing medications. And it is important to also manage the skin manifestation in this patient, where you can advise the patient to avoid exposure to sun or use sunscreen. You can use hydroxychloroquine for this patient. And if that does not work, there's also room for methotrexate in this patient. Thank you very much. I welcome questions, clarifications, and inputs. Thank you very much.
Thank you so much, Dr. Maduka, for the beautiful presentation. Thank you so much. So now we take some questions for the participants first, and then go on to our teachers. Okay, so you can raise your electronic hands. Okay, so let me take some comments on the chat. Okay, Dr. Maduka, I love
Dr. Kelly, please, can I come in? I think your network is.
A lot of thanks to you. So, Dr. is saying, thank you, Chief. Go ahead, please. Thank you.
Okay, thank you so much. Okay, thank you once more, Dr. Maduka, for that beautiful presentation. So there are a lot of people applauding you in the chat room. Okay, Dr. Ifamba is saying, thank you, Chief. Dermatomyositis, fine myositis has only cutaneous manifestations without muscle weakness. Okay, so Dr. Michael is applauding you, Dr. Mba is applauding you, Dr. Lalikon is saying, good morning. Thank you for the excellent presentation. I think roughening and cracking of the tips and sides of the fingers is mechanic hand. Okay, so that's what Dr. Olalikon just said. Every other person is applauding you for a beautiful presentation. Then also, Dr. Farida is saying, good morning. Thank you for the presentation. Starting induced myopathy should also be considered. Okay, then also Dr. Olarewanju is applauding you for a beautiful presentation, Dr. Oju, and also Dr. Musa is also saying a lucid presentation. Then Chief Remigos is saying, I thought the last one is called mechanic hands. Okay, so Dr. Maduka.
Okay, yeah, thank you very much for your comments and your inputs. Yes, like I said earlier, dermatomyositis can present with skin manifestation, and you can also have the skin manifestation without proximal myopathy. So if there is no proximal myopathy, it's called dermatomyositis sign myositis. That is if there is no proximal myopathy. But if it is just skin manifestations alone, you can now call it dermatomyositis sign dermatitis. No, if there is no skin manifestation, it is sign dermatitis. If there is no muscle manifestation, it is sign myositis. So yes, this patient probably has a form of dermatomyositis without the skin manifestation. Then yes, the roughening of the fingers. Okay, I saw somewhere that is the same sign, like I said earlier. But yes, there is also the antecedente syndrome, which is a kind of entity where a patient has either dermatomyositis or polymyositis with certain peculiar manifestations. So this patient will have Raynaud's phenomenon. The patient will have what they call mechanic hand, which is the fissuring and hardening, okay, of the hands usually. But I saw somewhere that okay, this is nail fold. Okay, so the fissuring and hardening is the one that is called the mechanic hand. But when there is nail fold telangiectasia and rag cortical, I saw somewhere that is called Summit sign. So I don't know whether they are the same or they are different. I don't know whether I've missed out any other comment or question, but these are the two I can remember. Thank you very much for your comments.
Okay, thank you so much, Dr. Maduka. There are other comments in the chat room, okay, and some others are applauding you, okay. Then Dr. Larry Wadri is saying, please differentiate between Shaw sign and V sign.
Okay. Can I see the head, please?
Yes, very much. You're very much.
Okay. Now, the Shaw sign, okay, in the in sun exposed area, usually it's assumed that okay, the whole body is covered. So around the neck and then the frontal part of the chest, where you have this V-shaped appearance, where as in the shirt or whatever clothes we wear will form this V-shaped appearance in the front, exposing the skin there. Now, the skin in the front is the V sign. Why the Shaw sign is the one we find, will I say, around the nuchal part, around the upper part of the neck. You know, when you wear it, the name is derived from wearing a shawl. There's this kind of thing people hang up around their neck. So the appearance at the back, upper part of the back, close to the neck, is a Shaw sign. Okay, while the one in front, you know, they are taking the shape of the exposed area of the chest is the V sign. I hope I made that clear. Thank you very much.
Thank you so much, Dr. Maduka, for your great inputs. Okay, so you have some more questions. Okay, so Dr. Temi Tope is saying the muscle enzyme is creatine kinase, not creatinine kinase. Okay, thank you so much, Dr. Temi Tope.
Thank you very much.
Okay,
thank you for that.
Okay, Dr. Yaya is saying, Dr. Yaya is saying, thank you for the good presentation. Muscle biopsy is important and can show perivascular atrophy. Steroid-sparing agents like azathioprine are important in the management. Intravenous immunoglobulin could be used in recalcitrant cases. Thank you, Dr. Yaya, for that great input. Dr. Sani Abubakar is saying, thank you, Dr. Maduka, for the beautiful presentation. I think myasthenia gravis should be included in the list of differentials. Another question should include ocular involvement and symptom severity with activity. Thank you so much, Dr. Sani. Dr. Ojo is saying the common underlying malignancies are melanoma, ovaries, non-Hodgkin's lymphoma, colorectal, and then breast cancer. So these are common malignancies associated with dermatomyositis. Thank you, Dr. Ojo. Dr. Ede Ifoma is saying violaceous erythema or poikiloderma involving the anterior chest is referred to as the V-neck sign, whereas involvement of the upper back and shoulders is referred to as the Shaw sign. So she's saying that the V-neck sign is the anterior chest, involving the anterior chest, while the Shaw sign has got to do with the upper back and the shoulders for the Shaw sign. Thank you, Dr. Ife Ede. Then Dr. Temi Tope is saying, how will you differentiate polymyositis from dermatomyositis sign dermatitis from the way you described it?
All right, thank you very much for all the comments. I agree completely. Now, for the differentiating, to differentiate between polymyositis and dermatomyositis sign sign myositis, right? Am I
Yes,
correct?
sign myositis. Yes, very
So
much.
now, to differentiate both of them, now we can start from history. From history, you find out that yes, both of them will have proximal myopathy, and but many texts will say that polymyositis usually will not come with pain. Okay, why dermatomyositis? Most times there will be pain. There will be pain or tenderness if you examine. Now, going towards the examination finding and the investigations now, you can find out that the dermatomyositis is usually the one that has the anti-MI2, okay? While the polymyositis, the antibody, the predominant antibody usually noted is the anti-JO1. Okay, these are the ways both of them can be differentiated. Now, also, if on history or examination you find an underlying malignancy, now you can now have to tilt more towards the dermatomyositis. So these are the few ways to differentiate the two that I can recall at the moment. Thank you very much. I welcome more inputs.
Okay, thank you so much, Dr. Maduka, for that great response. Okay, so Dr. Ikele is saying lung cancers associated with dermatomyositis. Dr. Yusuf is saying chest and abdominal CT scan to screen for malignancies, for important malignancies. Okay, thank you, Dr. Yusuf. He said you can actually do chest and abdominal CT to rule out malignancies associated with dermatomyositis. So Dr. Mustafa is also saying thank you. So I can't see any electronic hand up. So in the absence of further questions and add-ons, I would want to hand over the class to our Chief Christabel. Thank you so much, Dr. Maduka, once more again.
Thank you, Dr. Thank you, Dr. Kalamama. Thank you so much. Dr. Maduka, thank you. That was quite a wonderful presentation. Thank you.
Thank you, Chief.
From the way you answered the question, there is really nothing for me to add. You did well. I don't know if anyone has more comments. Any comment from our facilitators, Dr. Success, Jikoke, Chitu, Remigus, Fatima Okopi, and Sanda, Dahatu, Yahaya. I think I cited Dr. Atta. Any comments? Hello? Since there are no comments, so once again, Dr. Maduka, thank you so much. Thank you. Thank you so much for such a wonderful presentation. I appreciate you. I appreciate your effort. Doctor, thank you. I appreciate those that commented questions. The comments were quite on point. We just wish you could speak more so that it could be on recording. So, and also we also love hearing your voices. So please, thank you for all those that commented, those that have questions, those that put a wonderful comment. I appreciate you too. Thank you. Dr. Kalamama, over to you.
Okay, thank you so much, Chief Christabel. So we would move on to the next practice question, 1A. Dr. Jamila is actually standing in. So Dr. Jamila, please can you share the question with us? 1A. Thank you.
Good morning, my teachers and colleagues. Please, can someone help me share the question?
Labimpe, please share.
Thank you so much, Dr. Jamila, for standing in. Thank you.
Hello, can you see my screen?
Yes, I can see.
Hello? Okay. Let me mute, please.
Okay, can I start?
Yes, you can have the floor. You can have the floor. Thank you.
Okay, so I'm attempting station 1A. 45-year-old male with a 9-year history of G6PD deficiency and hepatitis C presents with fever and new parasternal murmur. Blood culture grew staph aureus. Echo revealed vegetations on the aortic valve. Urinalysis revealed 3 pluses of blood. Urea and creatinine were elevated. A. What questions would you like to ask him? B. What is the likely diagnosis? C. Mention other relevant investigations. D. Mention 5 other complications of the disease. E. Outline your management plan. And then how will you prevent this condition? So for the first question, what questions would you like to ask him? So I would like to ask him if there's history of IV drug abuse, if there's history of renal replacement therapy, if he's doing hemodialysis, if he had central line insertion, if there's any history of cardiac surgery, which include prostatic valve replacement or electronic devices, intracardiac electronic devices, if or heart transplant. I'd also like to ask if he had a dental procedure, including scaling and polishing. Then I'll also like to ask of um, systemic conditions like if he has diabetes mellitus. And then I also like to ask features of heart failure, if he has dyspnea, orthopnea, pedal swelling, or if there's history suggestive of stroke, sudden weakness of any part of the body. Then the next question, what is the likely diagnosis? So the likely diagnosis is acute bacterial endocarditis, using the modified Duke's criteria, where when you have positive blood culture, and then positive blood culture, that's when you have typical organism from 2 cultures. The blood cultures taken should be taken if you're taking 2 samples, should be taken to at least 12 hours apart, more than 12 hours apart. If you're taking 3 samples, it should be taken more than 1 hour apart. And then endocardial involvement, there's a positive echo finding of vegetations, and also if there's new valvular regurgitation. Then a definitive diagnosis is when you have when you have 2 major criteria, or 1 major and 3 minor. That's using the modified Duke's criteria. The minor criteria include valvular or cardiac abnormalities, IV drug abuse, fever greater than or equal to 38 degrees centigrade, embolic phenomenon, vasculitic phenomenon, blood culture suggestive growth but not up to 2. These are minor criteria. Then the next question is what other investigations I would like to do. So in this patient, they've already done the blood culture, the transthoracic echocardiography. They also mentioned the electrolytes, urea and creatinine, and then the urinalysis. So other investigations I would like to do include full blood count, ESR, C-reactive protein. I also like to do an ECG, chest X-ray, and then I also like to do liver function test, and abdominal ultrasound scan. Then the next question is what are the complications? Mention 5 complications of this disease. So they could develop perivalvular abscess. They could develop heart failure, myocarditis. They could develop embolic phenomena, which include stroke, mesenteric ischemia, splenic infarction. They could also develop arrhythmias. They could also have infectious aneurysm. Then the next question is outline your management plan. So for management of infective endocarditis would involve multidisciplinary team. I would involve the cardiologist, infectious disease physician, microbiologist, cardiothoracic surgeon, neurosurgeon, nephrologist, depending on the presentation of the patient. Then I'll place the patient on prolonged antibiotics, and then patient may also require surgery if indicated. Then the treatment it's depending on whether it is native valves or prostatic valves. If it is native valves, I would like to give antibiotic flucloxacillin with gentamicin, or I'll give vancomycin with gentamicin and rifampicin. Then for prostatic valves, I would like to give flucloxacillin with gentamicin and rifampicin, or vancomycin with gentamicin and rifampicin. Then the duration of the treatment is for 6 weeks. Then the next question is, how will you prevent this condition? So I would like to give antibiotic prophylaxis when performing high-risk procedures, and high-risk procedures. So high-risk procedures, high-risk patients include those that have cardiac surgeries, which include either prostatic valve replacement or cardiac surgery or intracardiac electronic devices. If the patient has past history of infective endocarditis, or has unrepaired congenital heart disease, or the patient is undergoing dental procedures, which will involve manipulation of the gingival tissue. Then the regimen for the prophylactic antibiotics in high-risk individuals include, it depends on whether they have, whether they are not allergic to. We give penicillin, so it depends on whether they are allergic or they are not allergic to penicillin. So if there's no penicillin allergy, I would like to give tabs amoxicillin. I would like to give tabs amoxicillin 2 grams start 1 hour before the procedure. Or if they cannot take orally, I would give them IV or IM ampicillin 2 grams start 30 minutes before the procedure. But if there's penicillin allergy, I would like to give them tabs clarithromycin or azithromycin 500 milligrams start 1 hour before the procedure, or I will give them IV or IM ceftriaxone 2 grams start 30 minutes before the procedure if there's allergy, penicillin allergy. Thank you.
Thank you so much, Dr. Jamila, for actually standing in. You were not supposed to take that, but thank you so much. We appreciate your efforts. Okay, so I would just add on, please, I want us to make contributions as regards this. Okay, so before we would have contributions and questions coming in, just to add on to what you just said. Okay, so for the aspect of questions you ask, like additional things, we can actually find out from them if they've had any history of central venous catheter, any history of recent hospitalization, if this patient has any soft tissue infection, and then if there's any history of if there are any extra cardiac manifestations. I don't know if that was mentioned. Like we also have the eye involvement in infective endocarditis. We also want to find out if there are any skin lesions in these patients, where we'll be looking out for the ocular nodes, the Jenrei lesion, the sphincter hemorrhage, and then looking out for petechia in these patients. Then also we can also have involvement of the spleen if there's any history of filling of an abdominal mass, like ruling out splenomegaly in this patient. Then also they can also have a neurological manifestations, as you mentioned, that they can present with CVD due to septic embolus being dislodged into the cerebral vessels. Okay, so these are things that can actually be added to it. Then in the investigations, like for the ECG most times is not really specific in giving the diagnosis. It's actually the echocardiography, especially the transesophageal. Okay, so basically the ECG just gives us a picture of an evidence of ischemic effects and then conductive abnormalities. Okay, we all know that here what is actually happening is that the endocardium is inflamed, and we know that the blood vessels actually traverse through the endocardium, that's the walls of the heart. So once it is inflamed, it impinges on the vessels, and then it also impinges on all those nerves, and also that's why most times it presents with features like ischemic features, and also present with conductive and abnormalities. So that's what we look out for in these patients in the investigation. Then also a full blood count. This is a chronic. This is something that has been ongoing. We can actually see features in keeping with pneumocytic, pneumochronic anemia in this patient, and then also WBC will be elevated because this is an infective process ongoing. Then we can look out for those immune complexes. We're saying that anything that can compromise the immune system can predispose these patients to infective and endocarditis. Okay, so we can actually do things like immune complexes, the rheumatoid factors, to rule out those autosomal or connective tissue diseases. Then, these patients, looking at these patients, aside the infective endocarditis, this patient actually has hepatitis C and viral infection. So we want to know, does this patient meet the criteria for commencement of medications? Because that alone can actually cause a poor prognostic factor in this patient. So we want to do hepatitis C and RNA to check for the load. If the patient meets, then we actually need to involve the gastroenterologist. Then we'll call the gastroenterologist to actually commence medications for this patient. Then also, going back to we can actually do peripheral blood film for this patient, because patients with G6PD can actually come down with methemoglobinemia, of which in this case they would need packed cell, transfusion of packed cell blood, and also they will need hyperbaric oxygen. So, looking at the patient holistically, we would also try to do investigations to make sure that they are stable in the aspect of their comorbidity. So these are things that can actually be done in this patient for investigating the patient aside infective endocarditis. Then coming down to the complications, they can also present with relapse. The moment they have some form of relapse, you're thinking of, could this patient have had an abscess around the valve? Because most times, sometimes when you treat them for 4 to 6 weeks, they still come down with fever. So when you suspect such a thing, you think of an abscess, and then you do a repeat blood culture. And if you isolate any organism, you continue to treat until that particular organism is actually completely treated. Okay, then going back to the management plan, you did a very great job. Okay, just to add on, like I said, that we should also look at other aspects in these patients, like the HCV and the G6PD. So now for the G6PD, we would advise them for the triggers, to avoid triggers in these patients, like those sulfur-containing medications, so that it doesn't worsen, because the moment they have the crisis, it can actually worsen the case in this patient. To avoid drugs like sulfonamide, the cotrimazole, the dapsone, chloramphenicol, nitrofurantoin, and also nalidixic acid. So these are things you would advise this patient, because this patient has G6PD. So dealing with this patient holistically, so that's what you would actually advise them to avoid. Then aside that, We also have a room in the principles of management. We also have room for surgical intervention. So a patient will actually need surgical intervention if there are perivalvular abscesses seen in this patient if we do a repeat echocardiography. And then also if the patient has an intractable heart failure due to valvular dysfunction, either from the vegetation being more than 1 centimeter, this patient meets the criteria for surgical intervention. Then also if there's a history of recurrent embolic events despite antibiotic therapy, this patient will meet indication for a valvular intervention, a surgical intervention, or if this patient has infection with aggressive organisms or persistent bacteremia, this patient would also need an intervention for surgical therapy. Okay, so these are the things I can actually add on. So talking about the pathophysiology in this patient. So the reason why we try to find out if there's any form of immunosuppression, if there's any form of sepsis, and also two things are actually implicated in the patients with infective endocarditis. There has to be, there can be, because we actually have the sterile and the non-sterile vegetations. So for the non-sterile vegetations, there'll be a presence of organism. Oh my God. Okay, there'll be a presence of a microorganism in the bloodstream, and then we'll have a background defect or abnormality of the endothelium. So basically, what actually happens is that we have two things that have to be met in this infective endocarditis. Number one, presence of an organism in the bloodstream. Then number two, when we have an abnormal cardiac endothelium that actually facilitates the adherence and the growth. So when you have all of these, what happens is that it then predisposes them to the vegetations. And the vegetation is actually a component of platelet deposits, fibrins, and then also the bacteria adhering to it. So all of these can predispose this patient to having this infective endocarditis. So that's what I have to say about making my contributions. Thank you so much, Dr. Jamila, for standing in. Thank you. Thank you so much. All right, so I'll go into the chat room and see what others have to say. Okay, so thank you, Dr. Yahya Mohammed. Dr. Yahya is saying thank you for the presentation. Another minor criteria is an echo finding suggestive of infective endocarditis, but not meeting up with the major criteria. Septicemia is a very common complication of this condition. So you also need to be careful in choosing some of the drugs you mentioned for treatment, as they can precipitate hemolysis in G6PD patients. Thank you so much, Dr. Yahya, for that great input. Well appreciated. Dr. Farida is saying thank you for the presentation. I came across a while back that the due criteria was updated in 2023. Can you share more light, please? Thank you. All right, so Kristen Ade to everyone. Okay, Kristen Ade is saying great presentation. I did not hear anything about the patient's hepatitis C in the management. Any comments in this regard? Okay, I actually talked a little about that. Thank you so much. All right, thanks so much for the presentation. It would be nice to ask if the patient has been treated for hepatitis C. Okay, thank you, Ikili. Also monitoring the renal function in this patient. Okay, thank you so much for that great input. Okay, Dr. Adeyanju, thank you for the great attempt. For prevention in the context of these patients, education on high-risk practices like the needle and syringe exchange programs, then also enrollment in drug treatment programs, continuous support and reassessment of high-risk practices, also education of the masses via advocacy, jingles, social support. Thank you so much. So she's actually talking about preventive add-ons with the preventive infective endocarditis. So she's talking about the enrollment in drug treatment programs, then continuous support and reassessment of high-risk practices, also education of the masses via advocacy, jingles, and social support. Okay, so yes, thank you so much for the comments in the chat room. I can see some hands up. I'm seeing a cardiologist trying to represent. I really appreciate. So Dr. Ojo, you can please have the floor. Thereafter, Dr. Fonte, you can please speak up. Thank you.
All right. Thank you very much, Dr. Florence. I want to also appreciate the presenter. He did a very good job despite the short notice. Just want to add some few comments. Dr. Florence has also made some many important comments. One is about the history. The history has to be very robust in this kind of patient because the history will guide us on all the associated risk factors. It also guides us in knowing the investigation to do for this patient and also guide us in the management. Now, apart from the hepatitis C, which we can maybe this patient has an injection drug to use and deficiency, history of congenital disease is very important in this patient. And if it was repaired, if it was fully repaired, and what kind of materials were used to repair, if the patient can volunteer such history, is very important. Because the other time, we're talking about the prophylaxis and those people that need prophylaxis. So those questions will be very important in the history. History of previous infective endocarditis will be very important in this patient. History of American congenital disease, history of heart transplantation. This patient is a recipient of heart transplantation. It's very important in this patient because it will influence the management and also it will be an indication for prophylaxis after you have finished treating this patient. So I just want to emphasize the importance of history. Then talk about ECG. ECG, as have been said, might not be so leading to a diagnosis, but there is something on the ECG that if you see it, it may be a pointer, and that is prolonged PR interval. The patient with IE has a prolonged PR interval more than 200 milliseconds. It could be a pointer to a possibility of aortic root abscess, and that would be an indication for surgery. So if there's another thing you want to look at in this ECG, please check out for prolonged PR interval because it can be a pointer to aortic root abscess, which, to friends as mentioned the other time, will be an indication for surgery. The other comment I want to pass is that this question has also helped us to some extent because we have the result of the blood culture that shows staph aureus. But the other thing that I have to do is that is a sensitive staph aureus, is a methicillin resistant staph aureus or not. So that will guide us in the choice of antibiotics. Because if it is methicillin sensitive, you can go for those antibiotics. But if it is resistant, then you have to go straight to gentamicin. Sorry, to vancomycin. You had gentamicin. Now, if this patient has history of processed adverbs, then we have to add rifampicin as the third antibiotics. So that's why I say that history is very important to tailor the management. And also, if the patient has a prosthetic adverb, then as part of the investigation, a transesophageal cardiography is very important in that setting because as opposed to, of course, some patients that are a native can also go for a transesophageal, but for the history of a prosthetic adverb, actually recommends strongly doing the transesophageal cardiography to diagnose this infective endocarditis. By and large, those are my comments. Thank you very much.
Thank you so much, Dr. Ojo, for that brilliant input. Thank you so much. Okay, so Dr. Conte, you can have the floor.
Yes, thank you very much to the presenter, and thank you to our other colleagues for the brilliant comment. Most of the comments have been made. Just a little addition so that we don't keep repeating. One of the things that we should be clear about is that, infective endocarditis, especially affecting the aortic valve, is one of the causes of acute aortic regurgitation. So because it happens suddenly and the heart doesn't have time to compensate for the regurgitation, they come down with severe heart failure. And as Florence mentioned, most of the time, even when you try to treat conservatively, it becomes intractable and you have to make a quick decision to go into surgery to help the patient. But surgery in acute infective endocarditis, when the infection has not been treated, is a really difficult situation. And so you need a very good team, cardiothoracic surgeon, anesthesia team, because you're infectious disease specialists all coming on board to manage the patients in this acute setting. And usually when you have when you're going for surgery in the acute setting, they'll prefer to go for a repair procedure if it is possible, rather than do a valve replacement. Because once you have an ongoing infection, putting a prosthetic valve, your risk of failure of the prosthesis with the ongoing infection is very high. So they want to try as much as possible to do a repair rather than a replacement. And also the ongoing inflammation of the tissue around the area that is affected also make it possible even to attach a prosthetic valve, because you can't even try to put a suture. The suture tear through the inflamed tissue. So around that acute period it can be difficult to do surgery, and they try as much as possible to do a repair procedure rather than a valve replacement because of all the attendant complication associated with it. Thank you.
Thank you so much, Dr. Conte, for that extensive inputs. Well appreciated. Okay, so we have Dr. Deyanju, another cardiologist, who also wants to make an input. Okay, you can please speak up. Thank you.
Thank you, Dr. Florence. Good morning, our facilitators. I just want to mention the NSP program again. I'm going to be talking about the prevention. So there's something called NSP, that's syringe and needle exchange program, because most people with IE, they are either had it, and when they are had it in industrialized countries, they actually create a program for them in which they come in, they try and exchange their needles for new ones and try to look at the practices in which they inject themselves, because most of them, they just keep reusing one needle. So in industrialized countries, they already have those programs, and those are one of the things that we should actually try and mention in exams, apart from the other things I've mentioned earlier in the chat. Then most of them, they have co-infection with hepatitis C, which is what is classical in this patient. In our environment, most people that have IE, they are either health workers, or maybe they are close to their hospital health workers, or they are close to easy access to having those things. So we need to actually include in their management, psychologist and mental health physician, and also to have a system in the hospital that checkmates them having easy access to all these medications that can cause IE. I think those are just the things that I wanted to add to the discussion. Thank you for the opportunity. Thank you, Dr. Florence.
Thank you so much, Dr.
Sorry, lastly, then in the management, there's something called OPAT. OPAT is an outpatient therapy that can be given to patients that they are no longer in the acute phase.
Dr. Deyanju, I don't know if it's just from my angle. I can't hear you again.
We can't hear Dr. Deyanju again.
Okay. All right, I think she's actually offline right now. Okay, so in the absence of further contributions and questions, I would like to hand over the class to our Chief, Chief Christabel. Thank you once more, everyone, for your contributions. Thank you. Chief Christabel, thank you.
Thank you. Thank you. I want to appreciate Dr. Jamila. That was thank you for coming to our rescue. This is something that we really love to see and we encourage. Thank you so much. Thank you. And the cardiology team, Dr. Ojo, Dr. Sonkonte, Dr. Kalamama, I think I said Dr. Yahaya, everyone that made one comment or the other questions, and especially the person that talked about the hepatitis. Thank you so much for bringing that one up. And that's something I noticed she didn't really dwell on. Because any question they give you in the exam, you try to talk on everything as much as possible. So that's why you go straight to the focus answer. You go straight to the question. But overall, thank you, Dr. Jamila. That was wonderful. Thank you. I don't know if any of our facilitators have any comments. Chief Remingos, Chito, Chief Cookie, Success, Dahatu, Fatima, Opopi. I'm happy the list is now endless. very soon hearing Ekele, Florence, Kunti,
Kalamama.
Release will become, etc, etc.
Now, I
Hello,
expect to hear something from Dr.
hello, ma.
Fatu.
It's not Kalamama, it's Kamala. So she's actually related to just a mistake in the name. Sorry,
Okay,
Yeah,
no problem. The next president. It's fine.
yeah, it's a coffee. It's not a serious person. Okay, but actually, I think the discussion, especially one on infective endocarditis, was just on point. I was almost protesting that I did not hear kidney. Then I heard someone saying you should monitor renal function. I said, yes, now you are coming. Because infective endocarditis can actually affect the kidneys. The subacute one now can actually cause a form of glomerulonephritis as part of the complications. Okay, so it was exhaustively discussed. I don't have anything to add. Thank you.
Thank you, sir. Thank you. The cardiology team did a wonderful job. Thank you so much, team cardiology. That's something we've always appreciated with them. They always come in when once is their question, and I'm happy that has not reduced with time. Thank you so much. Thank you so much, cardiology team, for doing justice to this question.
My comments have been taken over by the cardiologist, so it was a great discussion. Well done.
They did well. So they've practically